to the issue of financial toxicity. A little bit of my background. I thought it would be a good idea to get a degree in accounting because I've always liked numbers. Growing up, I always liked to figure out, these number questions, to figure out, the train is traveling this fast and all of that kind of stuff, right? So I got a degree in accounting. I actually did accounting for a year and was miserable. Sat in front of a computer and was typing in numbers and all of that stuff. And it's like, this is not for me. And so developed, it was an experience that I had where I decided I wanted to go into mental health and assist people. Had a deep passion back then to assist with end of life issues, helping people adapt and accept diagnosis where they were terminally ill. And so I naturally then landed into oncology, thinking that that would be a place where I could really do that type of work. And when I started doing that work as a social worker, as an oncology social worker, I kept getting bothered. And literally, this is how I felt, annoyed by all of these silly referrals that I would get for financial distress. I had the opinion that financial distress was not something that a mental health worker should be dealing with. We have hospital financial counselors in place that can do all of this work. And so I wanted to refer them to the financial counselors so that I could provide real mental health services for oncology patients. The problem was, though, that those referrals and those numbers of people in financial distress just kept growing and growing and growing. And unfortunately, when I would refer patients to the financial counseling office, only about 20% of the people that I referred got help. The remaining 80% didn't. And I decided, we need to do something about this. This is not working well. And then let me ask you guys a question. Is anybody here in the room ever heard of Dave Ramsey? Probably everybody, right? Now, he happens to be a multimillionaire because he has this idea of what people should do about their finances. Does anybody know what his basic premise is so that people are not in financial distress? What's that? Debt is evil. Yeah. I mean, it's very, very deep and complicated, right? So here it goes. Spend less than what you make, right? That's the basic premise of Dave Ramsey. It is simple. You can't get simpler than that. If you spend less than what you make, you will have less financial distress. Now, getting there is actually quite complicated in our society. Well, I had a similar idea when it came to financial distress for oncology patients. This very basic idea of going, if people were better insured, they would have less financial distress. Is that a fair statement? So it's a very basic concept, but very, very complicated to get there because of our health insurance system that we have here in the United States is very complicated. But I started spending a lot of time of taking a deep dive into health insurance, especially Medicare. Typically in oncology programs, 50% of your patient population is on Medicare. And so we also know that within the Medicare system, there are usually 30, 40, 50, 60 different choices that people have within that system of what they want for their coverage for their medical care in Medicare. Well, if you understand and if you navigate Medicare correctly, there are patients who have Medicare, and I'm not talking about Medicaid here, but who have Medicare, who can have 100% coverage for their medical care. Then there's patients who are on Medicare that could owe $30,000, $40,000, $50,000 for their care. So started taking a deep dive into this. And then one day, my life changed. Excuse me. There was a patient admitted to the hospital. She had just turned 65. So what does that mean? New to Medicare, right? So I looked at her face sheet and I saw Medicare as her primary insurance. And then I saw Medicaid as her secondary, but the Medicaid had a spend down. You guys have spend downs here in Kansas? I believe you do. Her spend down, when I went into the system to see how much it was $800 a month. So she was gonna owe $800 every single month before Medicaid comes in and pays the rest. So Medicare primary, if it's for outpatient care, covers her at 80%. She then pays $800 of that 20%, and then Medicaid pays the rest. Well, back then, this was 2006, there was a plan in Michigan available to her that was going to cost her, I think it was $38 a month, if I remember correctly. And with that Medicare plan, she would have 100% coverage for hospitalizations, 100% coverage for chemotherapy or infusions, 100% coverage for radiation treatments, and then some very small copays to see the doctor and scans. That plan cost, once again, $38 a month. So I decided I want to go and talk to her because are we potentially going to have a problem here with this $800 a month spend down? Yeah, we can predict that. So she was admitted to the hospital. So I knocked on the door, asked permission to come in. As I'm walking into the room, she's sitting at a table by herself and writing on a piece of notepad like this. So she puts down her pen and goes, yes, I'll be happy to talk to you. I'd say, hey, can I talk to you about your health insurance situation and to see if there's some ways that I can help you from a financial standpoint. So I spent about 45 minutes with her, taking quite a deep dive into Medicare, explaining how Medicare works, what are the differences between Medicare supplemental plans and Medicare Advantage plans and Medicare Part D. Took about 45 minutes. And she then, after those 45 minutes, said, well, yeah, why wouldn't I do that? I mean, I can afford $38 a month and have full coverage for my care. So then I spent another 15, 20 minutes with her explaining, here's how you can enroll into this plan. I'm all done and I'm gonna leave the room. And as I'm walking out of the room, she says, thank you. And I stopped and I said, well, you're so welcome. So glad that this was able to be taken care of for you and that you can enroll into this plan. I turn around and I start leaving the room and she says, thank you. So I stopped for a second time and did a little bit more small talk with her and said, you're so glad that this was taken care of. I am leaving for a third time. And she says, thank you, with much more force this time. So remember now, I'm a mental health worker. I have my master's degree in counseling. I should have picked up that something was going on, but I'm gonna be honest with you, I didn't. I walked over to her, I gave her a hug, said, I'm so glad that this was taken care of. We did a little bit more small talk. And I'm leaving for a fourth time. And this time, because I was standing right next to her, she grabbed my arm like this. She pulled me back. And then she changed my life. She said, she took her finger and she goes, you don't get it. And she was right. I didn't get it. She goes, before you walked into this room, I was sitting at this table writing my funeral plans because I'd made the decision not to get care because I knew I couldn't afford it. She goes, now I'm going to get care. And that's why I'm thanking you. I walked out of that room a completely different person. My attitude about financial distress, and that is not a mental health issue, was completely destroyed, right? I walked out of that room going, in our cancer center, we wanted to call ourselves a center of excellence, right? How can we be a center of excellence if we are allowing our patients to experience what she experienced? She had made the decision, I'm done. I can't do this. And we were not aware. We hadn't asked any questions about it. We had not paid attention to it. And in some ways, we are allowing this to happen to our patient population. I marched right down to the office of the director of our cancer center. And then I said to her, this was right afterwards. I said, how would you like to save $70,000 this year? And she goes, well, what do you mean by that? I go, well, let me just tell you about this experience that I had. What would we as a hospital system, a non-for-profit hospital system, what would we have done with her $800 a month responsibility? We would have written it off. Now, the patient didn't know that. I mean, we could still have gone to her and say, we'll just do charity on your $800 a month. Don't worry about it, right? Now we don't have to. And then I'm going to add in one more issue here. What is the mental health issue for that patient? Do you think that the vast majority of patients want to be a charity case? I don't think so. There are some, trust me, those of us that do financial counseling, financial navigation, we have people demanding, just give me charity care, right? But the vast majority of people don't. There's a mental health issue here where there is self-dignity that comes into play, where they want to pay their bill and they don't want to have to rely on charity. And I'm going to add in one more caveat here. When hospital systems, and I can't speak for your hospital system here and your specific one, but in many circumstances, when the solution to address financial toxicity is, well, we'll just give you charity, right? When we think about oncology patients, are they still going to be in financial distress? And in many circumstances, I should put it that way, in many circumstances, that patient is still going to be receiving medical bills from providers that might not be part of the hospital system that's providing charity. In our hospital system, the anesthesiologist is an outside provider. The medical oncologist is an outside provider. The radiologist, right? The pathologist. The list goes on and on and on, where the patient might still be flooded with medical bills that doesn't fall under the umbrella of charity care. So if we start being proactive about this, is what I was telling the director of the cancer center, if we start being proactive in addressing these issues with all of our patients, and if we start thinking about, because Medicare is so confusing and people are not picking wisely within the Medicare system, and people are picking free Medicare Advantage plans because it's free and they get their dental coverage in there too. And now they're not paying attention to that they're going to have a $7,550 max out of pocket responsibility with their Medicare plan. If we're not paying attention to this, and if we don't have somebody in the health system that can sit down and navigate our patients through these complicated scenarios, we're going to be losing money and the patient is going to be in distress. It's a loss. Why don't we move to a win-win, where if we navigate patients correctly through our extremely complicated health system, that's good for the patient. This is always second, but it's also good for us as providers. We move people to being more fully insured. So let me talk a little bit about this, and I'll give you guys some examples of what this has looked like. Not sure I need to read this. I don't know if you guys have read this while I was talking, but financial toxicity, we need to start thinking about financial toxicity from a clinical standpoint, right? Just like a medical oncologist is going to be deeply concerned about the cardiac problems that maybe chemotherapy might cause for a patient, or a medical oncologist is going to be deeply concerned about how much nausea this person is going to experience going through chemotherapy, right? radiation oncology are going to be deeply concerned about the tissues around where they're being treated, what harm is being done, right? So we, as healthcare providers, do a really, really good job, in my opinion, in the oncology setting of addressing toxicities that the patient might experience. Patient comes in for chemotherapy, we would think that it would be incompetent care if the patient comes into the infusion clinic and the nurse starts hooking the patient up for treatment and starts the chemotherapy treatments. And then the nurse says, by the way, this type of chemotherapy that you're receiving will most likely cause severe nausea. So if you experience nausea, please let me know. And then I'll contact a doctor to see if they can order something for you so that we can control that nausea for you. Is that what we do? Is that you guys can talk, by the way. No, right? We proactively treat, oh, this chemotherapy is going to cause nausea. Oh, here are some treatments on antiemetics that we're going to give you so that you don't experience nausea. But I tell you, we do this every single day when it comes to financial toxicity. There are patient populations that we already know that is going to experience severe financial trauma because of the treatments that we're giving them, but we don't address it. We wait for the patient to complain about the bill, and then we react. And then the social worker is pulled in, or if there's a financial advocate, the financial advocate comes in and sees what we can do to put a Band-Aid on this sore. What if we start looking at this proactively when the patient is coming into the system, identify patients who we know financial toxicity is going to come, and start addressing the issue from a financial navigation standpoint. Let me talk briefly here a little bit more on the psychology behind all of this, and then I'm going to move into more of the practical part of this. But I'm assuming that probably the vast majority of the people in the room went to college, right? So you guys know about Maslow. You guys took Psychology 101. Maslow is over 100 years ago. So I mean, I'm not saying everything that he said is perfect, but I do like the concept of what he said when it comes to being able to experience wellness in life. He said, in order to experience wellness, there are certain elements that need to be in place so that wellness can be experienced, right? And he started off with saying that if your physiological needs are not being taken care of, or if there's a threat to your physiological needs, it's going to be really difficult for that person to experience wellness. Well, when you get diagnosed with cancer, your physiological needs are being threatened immediately, right? I mean, you can die from this disease. But there's also a different component to physiological needs, and that's your basic needs. If you don't have shelter, I mean, do you think that person is feeling well, is experiencing wellness? No. Your physiological needs, your basic needs could be transportation, back and forth, right? Food on the table, those are basic needs. Now, I'm not saying that every single cancer patient is going to experience a threat to their, losing their home, putting food on the table, transportation, but there certainly is a high number of patients that do experience that. And I'm going to add in one more here. There is an additional percentage of patients who are afraid that they're not going to be able to pay their mortgage, they're going to lose their home, cannot make their car payment. And so there's a threat immediately with a certain percentage of cancer patients in regards to your physiological needs. Let's move up to the second category here, safety and security needs. What's within safety and security? Well, in our society, certainly financial is a huge part of us feeling safe and secure. It's not the only thing, but it's a huge part. How many in the room, if you guys wouldn't mind raising your hand, how many in your room have health insurance? Yeah, I think everybody in the room raised their hands. Well, why do you have health insurance? What's that? Well, but why do you have it though? Okay, you're fortunate. Okay, I agree. But you have it for what reason? You have it because of your job, right? But you decide to say, yeah, I want it, right? Security, right? I mean, if something drastic happens to you from a medical standpoint, at least you're protected. Why do we have car insurance? Why do we have health insurance? It's to protect us from a financial disaster that could happen, right? How many in the room are putting money away into some type of a retirement account? Almost everybody. I can't say for sure, but I think almost everybody. Why do we do that? Security, right? In our retirement age. So now let's go back to a cancer patient. They've been diagnosed with cancer. They're employed. They no longer can work, or they go on short-term disability, one of the two. So now there's an immediate threat to your insurance, your health insurance. Are you going to lose it? If you cannot keep working, are you going to lose it? Now, I'm very glad that we have the Affordable Care Act, because at least that's an option at this point, if not just through your employer. So your insurance is at threat. And then in regards to retirement accounts, they stop putting money into retirement accounts because there's usually a decrease of income, either no income, or maybe you're getting 60% of pay. And then worse yet, they're starting to take money out of their retirement accounts so that they can survive. So can you imagine, I mean, if you put yourself in this situation, can you see the stress level going up from a financial standpoint for not all, but a lot of cancer patients? Let's move up to the third one here, belongingness and love needs. Duke Cancer Institute has done a tremendous amount of research in regards to financial toxicity. In one of their studies, they found that 24% of the patient population that they studied suffered relationship problems secondary to the financial distress that they're in. So a quarter of the population is the relationship that they were in is suffering. Simple question. What's the number one reason for divorce? Does anybody know? There's actually two. There's two of them. They compete against each other. One of them is money. They fight over money. And then infidelity is the other one, right? So what I'm trying to communicate here is, are we paying attention to the distress and the trauma that our patients are experiencing as they're entering into the oncology world? And are we paying attention to what's happening to them emotionally, anxiety, stress level, from a financial standpoint? The number one reason why people are in prison is financial. What I'm trying to say here is that financial distress is extremely powerful. And are we aware of it? And are we paying attention to it? And are we trying to treat it? So a couple of statistics. 27% of adult insured cancer patients reported medication not adherence due to cost. So you're somewhere between a quarter and a third of your patient population are making medical decisions based upon the financial situation that they're in. A 2018 survey found that 57% of cancer patients expressed anxiety regarding the financial burden of care. And in the same study, this is fascinating, 54% expressed anxiety of dying from the disease. What does that mean? Patients, according to this survey, are more anxious about the financial obligation than actually of dying from the disease. According to the National Cancer Institute, 73% of oncology patients experience some form of financial toxicity. And then 7%, only 7%, I don't know if only is I don't know if I like that word, but I wanted it in there. Only 7% of commercially insured metastatic prostate cancer patients paid more than $100 for Zytiga on their first fill. 31% of Medicare beneficiaries paid more than $2,800 on their first fill of Zytiga. Now, if you guys are interested in financial toxicity and distress, and you've done reading about this, what you'll find in the literature is that the research shows that the ones that experience the most amount of financial toxicity is the younger population. I'm thinking that the reason for that is because they have less savings. They probably have less income, most likely, the younger you are. Not necessarily 100% true, but most likely they have less income, and their insurance is fully dependent upon, having that job, right? I'm telling you from a practical experience, most of my time when I'm working with financial distress for cancer patients, most of my time it's with Medicare beneficiaries. With the younger population, well, once again, I think it's because of their lower income. If there's more volatility, or they have less savings to go by, right? So there's more stress there. But with Medicare beneficiaries, you're going to see this in a little bit. 42% of all Medicare beneficiaries now are in a Medicare Advantage plan, and that's where I'm busy. Medicare beneficiaries saying, I cannot afford my care. Now, they're not at risk of losing their insurance, but what we're seeing there is very high out-of-pocket responsibilities for their care. And then the last statistics, and then we'll get into the meat here. 42% of newly diagnosed cancer patients have depleted their life savings within 2 years of their diagnosis. Once again, are we aware of what's going on with our patient population? So how has the healthcare industry, how are providers attempted to address this issue? Well, most hospital systems have what I call financial counselors. Now, please don't let the title confuse you, because there are hospital systems that have financial counselors that are actually doing financial advocacy and financial navigation. But what's more important here is their role. So most hospital systems have individuals in place that help people enroll into Medicaid and their charity program. That assists about 20% of the data shows that it's about 20% of the population that falls into this category. So what are we doing with the remaining 80%? Well, about 10 to 12 years ago, I think it started with oncology social workers going, hey, man, there is so much more that we can do for cancer patients than just charity and Medicaid. Pharmaceutical companies have free drug programs, there's copay assistance programs. So about 10 years ago, financial advocates that many times included social work sprung up and said, well, we can do so much more. We can enroll people into copay assistance programs and free drug programs and even basic needs programs, right? There's lots of organizations out there that will assist the patient with their car payment or their mortgage for a short period of time because there's been a significant decrease of income coming into the home. What I want to point out here is that this model right here, who do they assist with? What treatment modality is the main focus here? It's pharma, right? Copay assistance programs and patient assistance program is all pharma. Wonderful. I'm not complaining about those programs in any way, but cancer patients experience medical bills more than just from pharma, right? And especially if you're newly diagnosed, you come into the system, you probably start off with some type of a scan, and then they do a biopsy. Oh, now we need to do a PET scan. So the patient is already starting to get flooded with medical bills before we can even try to use these wonderful tools of copay assistance and patient assistance programs. And, patients might, maybe the treatment modality is surgery first, and then radiation is going to come in there someplace, right? And so these systems here do not address those other factors that the patient is receiving, where they're receiving medical bills. So this comes back to my Dave Ramsey theory here of, well, can we move patients to being more fully insured? Can we do what I call insurance optimization with patients? And that's what I call financial navigation. The focus really is on treating the problem rather than just the symptom, right? The problem is this patient is severely underinsured with whatever insurance that they have, and is there an opportunity to move them to better coverage? So let's give some, well, before I do that, financial navigation is a multidisciplinary approach to treating financial toxicity by proactively making use of insurance optimization techniques and a systematic process of utilizing external assistance programs. We're not going to throw out financial counseling. Medicaid and charity is appropriate in many circumstances or in some circumstances. We're not going to throw out financial advocacy. Copay assistance and free drug is appropriate in some circumstances. But we need to incorporate a much more, it's actually a much more complex, more difficult way of doing this, of fixing the problem from an insurance standpoint. And doing a paradigm shift in our brain that we need to start treating this rather than reacting to it, right? So it takes a team, which I'll talk a little bit about. It requires expertise, and then enhancing insurance, and then using assistance programs and taking a tactical approach. In many hospital systems across the United States, the financial counseling office is not part of the oncology program. They're probably part of patient access. And so the staff, the financial counselors, do not have easy or direct access to the oncology team. So in many circumstances, the financial counselors have no clinical background and they don't know what questions to ask. So they get a referral for a patient who's in financial distress. And I'm going to say they blindly treat those patients with, let's see if we can get you Medicaid. Or we can't get you Medicaid, let's see if we can get you charity. And that's it. Financial advocacy or financial navigation should be part of the multidisciplinary team. They should be fully aware of what this diagnosis is. There's a big difference from a financial navigation standpoint from a young lady who's been diagnosed with early stage breast cancer that needs a lumpectomy followed by radiation versus a person who's been diagnosed with multiple myeloma. The clinical differences are, completely different, and then there's different financial consequences because of that. And like, I'm just telling you, I'm not here to complain about financial counselors. That's not what I'm doing here, but they don't know. They don't realize these things. They don't have the experience and the clinical knowledge. So financial navigation should be fully aware of what the clinical needs of the patient is. How long are they going to be in treatment? Is this terminal? Is it not terminal? What are the side effects of treatment? How is this going to affect the patient's ability to work? All of those things. They should also be in close contact with and best friends with the prior authorization and benefit investigation department. The financial navigator should be bringing in cookies every single day and sharing it with this team because there's information over here that is critical for the financial navigator to be able to do their work well. Now that they have all of the information that they need, now we can start looking at, can we optimize coverage or just using external assistance programs as well? Now, another question for you all. How many in the room learned how to play the piano at a young age? Quite a few, right? So if you can remember, when you go back to those fun years, when the piano teacher sat down with you, probably the first thing that piano teacher taught you was posture, how to sit, and hold your hands, right? That's probably the first thing. But then the main thing that teacher is going to teach you is the scales, right? You have to learn the scales. And then you learn the scale on the piano in the key of C. Is that a fair statement? And then you practice that over and over and over again with your right hand. And you can start, it probably takes you weeks and weeks and weeks and weeks before you've mastered it with your fingers and you don't even have to look at the piano anymore, right? And then they say, well, let's move now to the key of F or the key of G, key of E, right? And you got to master this. And it takes months and months and months to be able to just, you can close your eyes and do it. And then you take in your left hand and you do the same thing over there, right? And it takes time to be able to master that. When it comes to financial navigation, here are the scales that are necessary and the scales that you need expertise in order to be able to navigate patients well. Probably 2 or maybe 3 times a month, my phone rings at my desk in the hospital, and it's, or an email, one of the two. And it's an employee or a manager or a director of the hospital saying, hey, I'm going to be retiring soon. Can you sit down with me and explain Medicare to me? Right? So if healthcare professionals do not understand this, and trust me, I've spoken to the president of the hospital, I've spoken to the vice president of the hospital, it doesn't matter their role. People do not understand Medicare. Now they might know, well, A covers hospitalizations, B covers outpatient care, and D covers prescriptions, but that's usually it, right? So if we as healthcare providers really struggle with understanding Medicare, what is it like for patients who don't even usually operate in this world? If a patient came up to you and said, hey, can you please explain Medicare Part D to me? Well, yeah, that's your prescription coverage. Yeah, but explain it. Well, you have initial coverage, you have the coverage gap, you have catastrophic coverage. You have $4,430 worth of prescription benefits in your initial coverage. Then you move into the donut hole or the coverage gap, and the coverage gap in 2022 is $7,050 long. Although because of healthcare reform, you're getting a 25% discount, but 95% of the cost of the drug is being subtracted from the donut hole. Then you move into catastrophic coverage where you have 5% coverage or $9.85 for brand name drugs and $3.95 for generics, right? And by the way, when can you enroll? When can you not enroll? Who should enroll? Who should not enroll, right? It goes deep, 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 deep. Do you have somebody in your healthcare setting that has become a master of all of these systems so that when patients are confused, somebody can answer their question? And the answer isn't, please call your insurance company to get that answer. I'm way behind here. I'm going to move on. What happened? Something happened.
I just went to the top of the screen and then...
So sorry.
No, you're fine.
Here's a 45-year-old. Let me just try to move it and see if it, yeah, it's working. Perfect. Here's a 45-year-old single female with 2 dependent children with a new diagnosis of lymphoma. She is self-employed with a yearly gross income of $85,000 a year. She is enrolled in an ACA policy, so she's enrolled in the marketplace with a max out-of-pocket responsibility of $17,100. That's the family out-of-pocket. It's April of 2022. She's had a 60% decrease in income since the diagnosis. And she needs, included in her treatment is biologic therapies. So first of all, what do you think it's like for her? What is her life like right now? What is she feeling? Scared, absolutely. She's responsible for 2 children. She's had a 60% decrease of income, and she's facing a $17,100 out of pocket. Now, every single day when I come into the office, I go through all of the new consults coming in because I want to proactively address the issue. When this lady came in, I go, I want to see her. Now, why did I want to see her? Well, now I didn't know this at the time. I didn't know how much she's paying for her policy, but this is her policy right here. She's paying $708 a month for this marketplace policy. And there's the $17,100 max out of pocket. Well, if we understand how the marketplace is put together, which will be on this slide here, you pay a percentage of your income toward the marketplace policy, right? And when you sign up for the marketplace in the fall, then you're telling the federal government, here's my predicted income for next year. That's how it works. Well, what do we know about cancer patients? Certainly if it's a bad diagnosis. Is there a likelihood of a decrease of income coming into the home? So now their prediction is incorrect, right? So in this circumstance, she was making $80,000. When we recalculated her income for the year, we ended up more in the, I think it was in the high 30s. So it was about a 50% decrease of her income for the entire year, okay, because it was April. So now, in many circumstances, what we're going to do here in most hospital systems is say, well, we can get her into a copay assistance program. Let's say she needed Keytruda. This is commercial insurance. We can use the Keytruda copay card that will help with this. But I'm concerned about, can you see this? I'm concerned about this. If you've had a 60% decrease of income coming into the home, can she afford $708 a month in premiums? I think her insurance is at risk of being lost. And if we're only relying on copay assistance, we have a potential problem coming down the road here. So in the marketplace, you're paying a percentage of your income. There's 2 different rows here because this is because of the Build Back, not the Build Back, the American Rescue Plan. Biden substantially reduced the premiums that people pay in the marketplace during 2021 and 2022. Her income was 80-some thousand, now it's like 38,000. So on the day of consult, she had just been told you have, what was her diagnosis? I can't remember. So you have this diagnosis, and I asked the doctor, how long will she be in treatment? 6 to 8 months was, I said, can she work during treatment? The doctor said, highly unlikely. So I was like, okay, I walked into the room after the consult and asked permission to speak to her. By the way, that's a whole other story. I see people on the day of consult. Social work doesn't like me to see people on the day of consult because they're saying patient is so much distress, you're going to add more stress. What is the #1 concern of cancer patients? Finances. They're already distressed about this. Why don't I want to be there on day #1 to start addressing this issue? So I addressed the issue on day #1. And I said, I'm a financial navigator. My role here at the Cancer Center is to reduce your financial distress as much as possible. I am not here to collect a dime from you. I am here on your behalf to see what we can do to help you. So she immediately says, yes, let's talk, right? I can count, I've done this now for 12 years. I can count on one hand of people who have said, this is not a good time. They had just been told, I'm going to die. They're going to die. Not a good time. 100% agree. But if I can count on one hand, people saying this is not a good time, there's probably over 1,000 patients that I've done this with that says, absolutely, let's talk. So when we recalculated her income, we actually went over and we called the marketplace together to say, hey, there's going to be a decrease of income. The 80,000 is no longer correct. Look what happens to her policy. Here's her new policy. She's now paying $85 a month, and then her max out of pocket went down to $2,450. Now, I could have just relied on copay assistance, but once again, this patient needed a scan, needed PET scan. There was another biopsy that needed to be done before we actually started with the immune therapy for her. So she was going to start getting flooded with medical bills. This prevented that from happening. And more importantly, you know, $85 is a lot more affordable than, what was it, 700 something, right? 67-year-old married female with a new diagnosis of renal cell carcinoma, monthly household gross income $1,680 a month, and they have $12,000 in assets. She has Medicare A and B only. What does that mean? And she doesn't have drug coverage, right? But with Medicare A and B only, you have a 20% responsibility, and that 20% doesn't stop. It's an unlimited 20% responsibility. When we estimated full cost of treatment, it was going to be $320,000 because she has a 20% responsibility. After the Medicare allowable, the patient was going to owe $44,000. Can this patient pay that? Can you imagine the stress level? And do you think some of these patients are going to say, no, not going to get treatment? I'm not going to do that. If I'm going to die anyway, I don't know if that was not the case here, but I'm not going to put my family in that type of financial distress. I have those conversations with patients on an ongoing basis. I'm not going to put my family in that type of a situation. Now, financial counseling would say, well, let's see if we can get you Medicaid. Can this patient get Medicaid in the state of Kansas? Why? 12,000. Her assets, they're because she's married, it would need to be below 3,000. What would Maslow say about that 12,000 and a well-intentioned financial counselor coming in and say, we got to get those assets below 3,000? Are we harming the patient from a safety and security standpoint? $12,000 is nothing for your retirement account, but it's everything for this couple. That's their tiny, tiny little security blanket. And I'm telling you, across the United States, day after day after day, well-intentioned financial counselors are coming in and saying, let's get rid of those assets so we can get you Medicaid. And I'm going to argue that we're harming the patient when we're doing that. We can go after copay assistance, but we would run out of copay assistance very quickly. We could try to get free drug from the pharmaceutical company. Yep, that would certainly work, but the patient remains underinsured for everything else. It's April. Can the patient enroll into some type of a Medicare plan in April? Open enrollment for Medicare is October 15 through December 7. So we're outside of the open enrollment period. Let me show you a few things here. In Medicare, there are two safety net programs. One of them is called low income subsidy. The other one is called the Medicare Savings Program. I'm running out of time here. I'm not going to go into detail about this, but these are two safety net programs in Medicare to help the low income individuals. This patient qualifies for both. The FPL of this patient, if I remember correctly, was 114. So this patient qualifies for Slim B, which pays the Medicare Part B premium. That doesn't fix that does not fix the 20%. But $170 more a month is going to come into their Social Security check if you do this. And because this patient is married, she qualifies as well. So they're going to be getting $340 more a month in their Social Security as soon as I enroll them into this program. Every state has this. Kansas has this. It's federally mandated. Low income subsidy. Here you have to be below 150% of the federal poverty level. And then there's asset qualifiers here as well. But this patient qualifies for this. And by the way, if you qualify for the Medicare Savings Program, you automatically qualify for level 2 of LIS. LIS fixes Medicare Part D. We still haven't solved the problem of the unlimited 20%. It's April, not open enrollment. But guess what? If you qualify for low income subsidy, or if you qualify for MSP, you can sign up for a Medicare Advantage plan anytime between January 1 and the end of September. Now, I'm not a fan of Medicare Advantage, but I'm certainly going to say it's 10 times better than having Medicare A and B only. I just randomly picked when I looked at some plans in your area here, so I'm not promoting Humana, but this patient can sign up for this plan It's April, right? They can sign up for this plan, and if they do it in April, it will go into effect May 1st. Look at this. The plan doesn't cost anything. For nothing. They'll get a little dental, they'll get a little hearing, vision. But more importantly, what's important here is the max out of pocket is $3,450. Would you argue that $3,450 is better than $44,000? Even if you're not good at math, I think you'd know that one, right? For no premium. So you can enroll into this outside of national open enrollment. Now, about 30% of all Medicare beneficiaries would fall into this category where they qualify for low-income subsidy. So that means that there's 70% that wouldn't. Well, there's another rule, 5-star rule. Has anybody in the room ever heard of this 5-star rule? There's a rule in Medicare or Medicare Advantage that if you have a 5-star rule or 5-star Medicare Advantage plan in your county, guess what you can do? You can sign up for that plan any time during the year. There is no open enrollment period. There's year-long open enrollment period. In my opinion, if your county has a 5-star rated Medicare Advantage plan, there is no longer any reason why you would have Medicare A and B only patients. Nationally, 10% of all Medicare beneficiaries are A and B only. I guarantee you, you have them. They're in your system. There's no longer a reason to do that if you have a 5-star rated plan. I randomly did like 10 different zip codes in Kansas and found that about half of them had a 5-star rated plan available. Here's a 5-star rated plan. Now this one does cost $48 a month. And then the max out of pocket is $4,500. Now that we've done this, now we can look at external assistance programs and patient assistance programs or copay assistance programs. Here's renal cell through HealthWell Foundation. Here's a $10,000 grant that will assist with the biologic therapies on that $4,500 or $3,450 max out of pocket. That intervention saved the patient $44,000 and an unnecessary bad debt or charity for the hospital system if you're going to do charity for this patient. Medicare Part D. Remember I was trying to explain Medicare Part D to you. There's initial coverage $4,430, $7,050 during the donut hole, and then 5% responsibility. On oral oncolytics, what most people are going to be paying in the Medicare Part D system is 25% during the initial coverage and 25% of the donut hole. So if there's a $15,000 oral medication that this patient is filling, which is very common in the oncology world, they're going to be paying 25% of $4,430, 25% of $7,050. We're at about $2,800 right now. And then if it's a $15,000 medication, we have about $3,500 left, right? 15,000 minus 4,430 minus 7,050, about $3,500 left. So 5% of that, that would be, my brain isn't working right now, for about around $200, rough numbers. So about $3,000 the first time a Part D enrollee is going to be purchasing or filling an oral oncolytic. Then they go into catastrophic coverage, where they're paying 5% of the cost of the drug. So here's a 69-year-old married female diagnosed with advanced stage breast cancer. Monthly household gross income $1,840 a month, and they have $24,000 in assets. She has Medicare Advantage plan, which includes Part D. She needs Ibrance. Here it is right here, Ibrance, $14,000 medication. These numbers are not correct. The Medicare website does not calculate the copays correctly. What it's doing is it's taken 25%, because they're paying 25% during the initial coverage and the donut hole, of the full cost of the drug, but it should be 25% of 4,430 and 25% of 7,050. This has always been this way since the Medicare created this website. It's been like this for over 10 years. They haven't fixed it. I don't know why. But what I want you to pay attention to here is that most cancer patients, or most patients, are on other medications as well. And if we take the financial advocacy model, it says, well, we can get you copay assistance for this. Well, for those of us who do the work, foundations out there are often closed to help with these large copays for breast cancer. We can try to get free drug for the patient from the pharmaceutical company, but once again, that fixes it for this, which is nice. That's a big problem solved, but the patient continues to have copays and out-of-pockets for other medications. Insurance optimization would look at, she qualifies for low-income subsidy. Her income and assets meet that criteria. 30% of all Medicare beneficiaries qualify for extra help. Guess how many are enrolled? Only half. It is a highly underutilized program. Half of people who qualify for this is enrolled. Look what happens to her copays if you enroll her into low-income subsidy. Ibrance now costs $9.85, and the first time you fill it, right, it's a $14,000 medication. They would pay $9.85. That now puts them into catastrophic coverage. What are the copays once they're in catastrophic coverage? Zero. And what are the copays for all of her other medications? Zero. What I'm trying to articulate here, and then I need to end here pretty soon because I want to take questions. What I'm trying to articulate here is that what kind of a model do you want for financial advocacy? A model that zeroes in on a specific problem that the patient has, like a copay for Ibrance, or a model that is treating the patient. I've had conversations with hospital systems over and over again. I say, you need to enroll you need to assess every single Medicare beneficiary for low-income subsidy. Well, why would I do that? I mean, I only need to do it for people who are on Ibrance, well, or an expensive oral drug, right? You're putting a Band-Aid on the sore. You're narrowly treating financial toxicity when we should be broadly treating it. Am I making sense? I don't think I'm explaining myself really well here, but now that we've done insurance optimization, can we fix the insurance? Can we make it better for the patient? Now our attention moves over to all of the external assistance programs that are out there. There are many. Here's one for pancreatic cancer through Cancer Care. There is some software platforms out there now that really does this well, not the insurance optimization part, but the external assistance programs. So AssistPoint, Atlas, TaylorMade, Viver, and TaylorMade and Viver, TaylorMade purchased Viver. But these software programs will integrate right into your EMR and then pull out patients. Here are the 17 patients today in your infusion clinic that you can do copay assistance with. Or this person has been diagnosed with breast cancer. Hey, you can use the Pink Fund for this patient, right? That type of stuff. Full disclosure, I'm a consultant with TaylorMade, so just so you're aware of that. But it makes life so much easier for the financial advocate, because you don't have to do the treasure hunt and spend 15 minutes trying to find all the programs. You'll have it within 2 seconds. The return on investment is very significant. Here's a hospital system. They implemented this. They see about 1,800 new cases per year, and their return on investment was $2.3 million in 1 year. And then it reduced patient responsibility of over $7.5 million by taking this approach. Unfortunately, there are no, there's almost no training programs out there on this type of stuff. ACCC has the Financial Advocacy Boot Camp. That's a self-learning portal, so you can go through different PowerPoint presentations. I assisted them with developing some of that, but it's all self-learning. It is legally okay, I don't know if that's the right word, for a cancer program to walk out on the street of your building and randomly pick a patient or person and say, you can start tomorrow as my financial advocate. There are no licensing requirements. There's no educational requirements out there for the role. Anybody can be hired for the role. And then we scratch our heads going, why do we have so much financial toxicity? People need, just like physical therapists, nurses, physicians, the list goes on and on. They all are required to go through special training to be able to do the work they do. But the number one stressor of cancer patients, no requirements. Training is critical. I'm not trying, I want to do a shameless self-promotion here for 10 seconds. My consulting work is I provide training. It's 2 days intensive training followed by 12 months of mentorship, a remote mentorship. This work is not easy. It's I've had I've had people go through my training and halfway through it broke down in tears because it gets quite intense. Because it's a lot of data, it's a lot of insurance rules and all of that stuff. But it's worth it for the patients, in my opinion. It all goes back to you need to have expertise. Without the expertise, financial toxicity, I think, is going to continue to flourish in your system. A couple of suggestions and then I'm done. Please recognize that financial toxicity is affecting your patient population. It's occurring there. You might know it, you might not be aware of it. Most patients should have a touch point with financial advocates, a financial advocate. I'm not saying that 100% of patients need this. There are many patients who are fully insured already, and let's not waste our time. But most patients should be seen. Please, there is a stigma with financial toxicity that our patients are going through. There is shame. They don't want to bring it up. They're embarrassed. Please let them know they're not alone. Right? You have full-time financial advocates because this is an ongoing problem. Every infusion patient who qualifies for copay assistance should be informed of its availability. Every Medicare beneficiary should be assessed for MSP and LIS. The financial navigator role should not be blended with other roles. Unless if you are a very small provider and you only are seeing 200-300 new cancer patients per year, well, maybe the social worker can take on this responsibility. But the role is complicated, and usually whatever they're passionate about is going to take precedence. In my opinion, you should have a minimum of a bachelor's prepared person in this role. They need to have passion for the role, some clinical understanding, some mental health experience, because we're dealing with a very sensitive topic, and some experience with health insurance policies. All right. If you're interested in reading more about this, please give me your business card, and then I will email you some articles about this model. All right. Why don't we take questions?
That's great. Thank you so much. That was everything I thought it was going to be. I've heard you speak before, and you didn't disappoint today. So thank you so much. We'd like it to open up the questions, even if we go over just a little bit, because I know this is such a burning issue for so many of us. Terry, and then I'm going to ask you to hand the mic to others, okay?
Absolutely. Thank you so much for the info. Question: how do you find this person who has all of this insurance information and clinical?
Right.
Is this nurses? Are these social workers? Give me who's successful in this?
Is this on?
Yes.
Okay. So it's not easy, right? For me, the issue is you need to find somebody who is passionate about this. October 1st is the day that the following year's insurance plans become available for public view in Medicare and the ACA. And this is going to sound strange to you, but October 1st is Christmas Day for me, right? I love this stuff. And so finding somebody who is really interested in helping patients from a financial standpoint is, you'll go a long ways of being able to be successful in the role. There's been 2 different job descriptions that I've found that actually works really good in the role. Social work is one. Their heart tends to be on the patient, right? And it has to be. This role is all about the patient. I've also had some health institutions that have, this might sound strange here, but no clinical background, but they have an MBA. And they're fascinated with numbers and dollars and stuff like that. And it's been very successful in those hospital systems where they required a master's degree, and they've had actually MBAs apply for the position because they have a heart. They want to work and help people. I don't know if that's a short answer that maybe for at least a half an hour conversation. But.
Other questions? Steve?
I found this fascinating. So are there outside of the hospital systems, organizations that would help people navigate this? There's a lot of people raising a lot of money. Are any of them providing services in this area?
Yeah, so there's an organization called SHIP, State Health Insurance Assistance Program. Every state has it. Their expertise is Medicare, Medicaid, and they can navigate people through the Medicare system. My concern about using an outside system to do this is that they don't have, or it's much more difficult, direct knowledge about the treatment plan, the diagnosis, how are things going for this patient? Can they work? Can they not work? So you lose a little bit, but there are. TaylorMed, they have their own financial navigation team. Now you have to purchase that, when you purchase the TaylorMade software, but they have a call-in center that can help navigate some of these things as well. I'm just concerned that you'll lose a little bit here in regards to
Tracy?
Yes, Dr. Doolittle, can you hear me?
Tracy, do you have any questions from the chat?
Carla, the sound is turned off probably on our computer.
Thank you, Hope. You're right.
Oh, it is.
Anybody here? Questions?
It didn't, it's still, there we go. Okay.
Hi,
Tracy.
Dr. Doolittle, can you hear me?
Yeah, we
Yes.
can hear you. Great, Tracy.
Fantastic. We do have a couple of questions in the chat. Do we have an idea of how much toxicity occurs as a result of health insurance claim denials? And is there a role in navigation for addressing this?
I'm not going to have a specific number on that. I think I've read, there's research out there that shows that up to 80% of all claims, there's a mistake in there somewhere. You saw on my slide here, on one of my slides I had, and I didn't discuss it because I'm running out of time here, but that the financial navigator should have a contact person in the billing office. I have found that the billing office, they don't have direct patient contact, and they speak a completely different language than what the patient does. And so I, as a financial navigator, am a mediator between the two. So often, when there's a billing error and that kind of stuff, then I'm working directly with the billing office rather than relying on the patient trying to work with them. It reduces a stressor for the patient.
I'm going to ask you, can you repeat just a little bit of that? Sorry, they're having a little trouble on the Zoom call.
So I have found, in regards to billing error mistakes, that that the financial navigator can be a mediator for the patient. The billing office doesn't speak the same language as the patient does. I've found that over and over and over again. I've had patients call me left and right going, I'm getting so frustrated with the billing office. Well, why don't I just do that for you? I have the privilege of working very closely. We share an office with the person that does the prior authorizations. If we see that, insurance is denied, boy, he's the first person I'm going to go to. Why is this being denied? Oh, I see what's going on. And then, we try to fix it. That could take weeks and weeks for the patient to try to figure out when we can do it in seconds. Other questions?
I do have another question. If you have a 3-year colon cancer survivor who is about to file bankruptcy due to treatment debts he has accrued from his treatment, what suggestions would you have to offer them, if any?
So that is extremely difficult to answer because it all depends on so many scenarios. What kind of insurance do they have? What is their age? What was their income? The answer is going to be different for each unique individual. So I don't even know where to start. If you have a qualified financial navigator in your system, it needs to start there. That person should go and see what can be done. There are. I was out in Wyoming about a year ago, and providing the training for a hospital system in Wyoming, and the director of the billing office was there and listening to the training, and he goes, Dan, I have 3 patients right now. They were all breast cancer patients, so they had all received Herceptin for treatment. And she goes, we have 3 patients that owe us over $300,000. They're paying us $200 a month. They're never going to get out of it, right? They're going to be in this payment. Well, they were all self-pay patients. Wyoming, just like Kansas, did not expand Medicaid. So 3 self-pay patients owing $300,000 each. Well, in that answer was, well, let's reach out to Genentech to see what they can do and see if they can replace the product. All 3 of them, we got it replaced. So it all depends on the scenario. We'd have to do an analysis of the situation in order to come up with a good answer.
Fair enough. Any other questions? One last question. We good?
Dr. Doolittle,
Please.
it's me over here. One of the reasons why we invited Dan, you can see this is fantastic, right? Like so much good information, but we're always thinking about what would be useful to the hospitals that are part of the MCA. And I really want you all to think about, like, if this is something that we need to start considering as a member benefit, or offering some of the support for the training so that you could hire someone to do that, have your hospital talk to me. And we haven't figured out what that looks like or how much we could support it. But if this is something that's really of value, then that's what your MCA membership is about. Like, what can we do together as a group across the state and the 18 counties in Missouri to make a difference for individuals who are facing cancer? And so this is one example. There's lots of other examples. You may say, well, there's something else really that we need to do that will make a difference in my community. And we want to hear that too. But I just really appreciate, Dan. You were amazing.
Yes.
And we appreciate your time too.
Yes.
And you're staying for a while.
Yeah.
We purposely kept you here through lunch. We purposely did this so that we'd be entering into lunch so that you all could have time. I don't know if Dan will get to eat, so make sure you put your food, grab your food first.
No, I'm happy to answer any questions. I think I have to leave right around 2:30 for my flight. So I'll stay here and my heart, I have passion for this, right? It's about helping patients. And so ask any questions you want. I'm more than happy to try to answer them.
We can't thank you enough.
Yep. Thank you.
So outside these doors, we have food. So you can go and they are individually packed, so you can pick